So once again, thank you everybody for joining us today on a Saturday evening. My name is Parth, and this platform is called Nivarana. For those of you who are joining us for the first time, Nivarana was founded in July 2022. And a basic aim of Nivarana is to increase awareness regarding various public health issues. And we're also trying to create a platform where people working in the field of public health in different parts of the country, in different parts of the world, can come together and discuss various public health issues. And for that very purpose, today we have Dr. Swathi Krishna, who will be talking to us about TB. We all know TB is a major issue in the country, and the government is trying to end TB by 2025. So we'll be discussing today, is it really possible? Is anybody who's working in different parts of the country, what have they been experiencing? Is it ending in reality or it's just on paper? And for that very purpose, we have Dr. Swathi with us today. Dr. Swathi has done her MD in community medicine from Christian Medical College, Vellore. And she has been a former consultant for the NTEP, a national consultant for NTEP in India. Thanks a lot, Swathi, for joining us today. And I will hand over the mic to you now. Please go ahead and share with us whatever you have planned for the day.
Yeah. Thank you so much, Parth, for that introduction. And thank you everyone for joining us on Saturday evening. This will be a session where we are just discussing about the global burden of TB and where India stands in that entire world's TB picture. And I would like to put the disclaimer at the beginning itself that I won't be going into the details of NTEP, National Tuberculosis Elimination Program, in the session per se, but of course in the discussion question and answer session, we can discuss about specific doubts, because NTP as itself is a very huge topic. So our purpose here is to discuss about what is the status or the burden of TB in India and how close are we to achieve the targets of NTB by 2025. So we'll start the session. Please feel free to put forward your questions. We would really appreciate it. So I'm just sharing my screen. Please let me know if it is visible.
Yeah, it's visible. If you can just make it like
slideshow. Yeah. Is it okay? Okay. Yeah. Okay. As an outline of the session, we'll be introducing, or we'll be discussing a bit about the Sustainable Development Goals, SDGs, the NTB strategy by WHO, the UN high-level meeting, UNHLM targets for TB, and India's national strategic plan for TB elimination. Also, we'll touch upon the key features and policies in NTB, status in global TB map, which is what we are discussing in detail, the progression to achieving various targets defined by SDGs or NTB or UNHLM. So how much close we are to achieving those targets, a conclusion and a way forward. So this is in a nutshell what the session would be about. So Sustainable Development Goals, SDGs, you all are very much familiar with. Anybody working in the field of public health will definitely know about Sustainable Development Goals. It was adopted in the year 2015, and the global nations identified 17 specific areas where they could work upon towards achieving overall development, human development for their countries. So though the 17 areas are separately identified, we all know that all these are very much. So suppose if we focus on the third goal, that is good health, it is already known to us that We cannot achieve good health by working in that specific domain health alone. The goals of no poverty, no hunger, clean water and sanitation, each one of the 17 goals for that matter is very much contributory to achieving the third goal. So all these 17 goals are very much interconnected, and any event in any of these domains is contributing to the achievements in other domains. So SDGs we all are familiar with, and TB sits at the heart of these SDGs. So though TB is directly put in the third goal, which is good health and well-being, and one of the targets is to end epidemics of AIDS, TB, malaria, and neglected tropical diseases. It is very much connected with the first goal of ending poverty in all its forms, the second goal of ending hunger, the goal of reducing inequalities within and among countries. So it is not only these three goals alone, but TB, in the context of TB, if you approach SDGs, every goal has something to contribute towards it. So that again comes back to the point which I was discussing in the previous slide. They are all interconnected. Now, what is UNHLM 2018? For the first time in during this period, before that, let me tell you, during this period of 2014 to 2018, some significant changes happened in the global policy level picture, and that was in terms of the adoption of SDGs, Sustainable Development Goals, which happened in 2015. And the countries were committed to achieve those goals by the year 2030. Also, WHO adopted End TB strategy a year before SDGs, but after the adoption of SDGs, they slightly focused their targets in terms of TB. I'm speaking in terms of TB. After the adoption of SDGs, WHO also streamlined their NTB strategy with renewed targets. So post 2015, the NTB targets are with a renewed vigor. And also in 2018, UN United Nations convened the first ever high-level meeting, which was exclusively on TB, which urged the global nations for a united effort to end tuberculosis. And they recognized it as a global epidemic, and the requirement for an urgent global response was identified, which led to an accelerated progress towards NTB targets in terms of treatment, the case notification, treatment, better treatment opportunities, increased financing, more research and innovation, more political commitments. So all of these came into being with these high-level policy-making meetings which happened during this period. And India is, of course, a signatory to these bodies. So India is also bound to achieve these targets by the set dates. Now, little bit about the SDG targets and WHO's NTB strategy. So you can see the WHO has put forward the NTB strategies, and the target year for achieving those strategies is 2035. And SDG, on the other hand, the target year for achieving those targets is 2030. And there are certain milestones, kind of interim assessment, which you have to do during this period. That is in the year 2020 and in 2025. So we have already well-defined TB elimination achievements. So let's see what they are. So if you see end TB targets by 2035, the world is supposed to reduce the number of TB deaths, or what you call as TB mortality, by 95% 95% from what? From the baseline data, baseline of 2015 level. So whatever TB deaths we were having in the 2015 year, we are supposed to, the global nations are supposed to reduce TB deaths by 95% by the year 2035. So for all these targets, the baseline year is 2015. So compared to 2015, it should be reduced by 95%. And the TB incidence rate, the new cases of TB occurring every year, that should be reduced by 90%. And of course, the catastrophic cost due to TB should be 0. And you see the SDG targets, which is to be achieved by 2030. We should reduce TB mortality by 90%, and the TB incidence rate should be reduced by 80%, and catastrophic cost 0%. So the milestones are set for 2020 and 2025, where countries are supposed to look into their achievements in terms of TB reduction in TB mortality and TB incidence. Now, to achieve this SDG by 2030, India would require to decline its annual TB incidence rate at least by 11%. Then only we can reach this 2030 levels, 2030 SDG goals. But what is happening now? Currently, we have a decline rate of only 2.5%. And another twist to it, in 2019, the government of India declared that we will achieve the SDG goals by 2025, 5 years ahead of what the world targets to reach. We, government of India, committed to reach the SDG goals by 2025. So, which is what you hear by the slogan TB Mukt Bharat by 2025. So there is, of course, a renewed vigor or renewed urgency among the government departments to end TB by 2025. But how much of it is practically possible? That is, again, the question in front of us. So little bit into the history of TB control programs in India. TB control programs have been there in India from pre-independence times, because TB has always been a problem in India. And like prior to independence, mostly a sanatoria-based care which was being given. The TB sanatoriums were constructed across the country in various places, where TB patients were put for treatment and provided with good nutrition and they'll be mostly well-ventilated places. So the importance of nutrition and good ventilation was realized or recognized from olden times itself. And the drug was administered within the sanatorium. The people were supposed to stay in the sanatorium and take treatment. They should be isolated from the normal family members who have not contracted the disease. That was the idea at that time. And in 1962, we had a formal program, National TB Control Program. BCG vaccination was started in India back in 1948 itself. And in 1997, the program underwent a major change by introducing directly observed therapy short course DOTS in revised National TB Control Program. And this was, RNTCP was the program going on till 2020, when as a result of all these high-level meetings, the UNHLM meetings, SDG targets, and NTB strategy by WHO. So based on all of that, India also entered into the mode of TB elimination. So that's when the program was renamed as National TB Elimination Program. So it's no longer RNTCP, it is NTEP. And this kind of changed the focus or our attention towards elimination of TB. So it is kind of the focus should be on elimination. So to emphasize that, the program was renamed. Accordingly, there are strategic changes also in the program. It's not a name change alone, but there are strategic changes also. So what are India's targets? It is to end TB by 2025, which is 90% reduction in TB deaths and 80% reduction in TB incidence. Now, India has a very well-written national strategic plan to end tuberculosis in India, what we call as our NSP. This is the guiding, guiding document for the TB program in the country. So the first version of this NSP was put forward in 2017. It was called National Strategic Plan to Eliminate Tuberculosis in India. So that was drafted and put in the public domain, and it invited public suggestions as well. So based on that, they redrafted the strategic plan with modifications, and currently this is the National Strategic Plan to End Tuberculosis in India 2020-25. So this is the guiding document for all the activities related to TB elimination in the country. It's a beautifully written document. Anybody who is working in TB should go through it. Otherwise also, like anybody working in public health should be going through it. It's a very well written document. If implemented 100%, there is nothing like that. So it's a very well written document. So a little bit about the National Strategic Plan. It has 4 major pillars. It was called pillars in the first version, but in the second version, they identified that building systems is the base or the foundation for everything. And they converted the pillar into that base foundation, the build, strengthen, sustain. So that is the foundation for every other activity. So in build, the program envisages a fully strengthened system, government and program management mechanisms, procurement and supply chain management, research and development activities, human resources development, everything is to be strengthened. So if you go through the NSP, this build part describes everything regarding the strengthening of systems within the TB control program. And on top of that, on the build platform, you have the other strategic pillars, which is prevent, detect, and treat. And under prevent, we have our TB preventive treatment and latent TB infection management strategies. We have infection control measures. All these are under the prevent pillar. And in the detect pillar, we have the the diagnostic strategies, TB case finding activities. Everything is described in detail, how to go about it. And under the treat pillar, we have the drug regimens, drug sensitive, drug resistant TB, priority populations, what all other focus areas. Everything is described under treat. So this is in nutshell the National Strategic Plan for India. Now, key features of NTEP policy. What are the key features of NTEP policy? The age-old microscopy, which is sputum microscopy. That was the gold standard for, sorry, not the gold standard, but that was the most widely used test for diagnosing TB in India. So, but it is a very less sensitive test. It requires a lot of skill. It requires a lab technician to read the, trained lab technician to read the slides. And even after that, the sensitivity is not great. So microscopy is slowly being phased out of the program, and rapid molecular tests, CB-NAT and TrueNAT. So upfront NAT is the policy. So in the first place itself, offer the patients NAT. That is the policy of NTEP. And universal drug susceptibility testing, or UDST, plus chest X-ray. So this is the policy in NTEP now for case diagnosis. And if you are familiar with the lab setup, I would say the TrueNat technology, that really is a game changer. Rapid molecular tests in general is a game changer in TB diagnosis, but TrueNat in particular made it possible to do rapid molecular testing even to the most peripheral level, because TrueNat is truly a portable system. CBNat, on the other hand, is a huge machine which is placed in sophisticated lab, and you require certain infrastructure to maintain it, whereas TrueNat is a battery operated machine. You can plug it in the power cord also. So it is truly portable machine, which has made diagnosis of TB so easy and so peripherally accessible. So that was one game-changing introduction into the TB program of the country. Now we take 2 sputum samples, one early morning and another spot sample. And for pediatric TB, we have induced sputum sample or gastric aspirate for NAT. So that is the key things in NTP policy. And regarding the DRTB regimens, what do we have? So the drug regimens, we have few drug regimens in practice for DRTB in the program. The shorter oral regimen containing bedaquiline, the longer oral regimen. So these regimens, and also the BPAL regimen. So all these regimens are to be decided based on the drug susceptibility results of the patient and also their tolerability to certain drugs. And also by policy since April 2022, no patient is to be treated with an injectable drug. We are supposed to offer them oral medication. That is by policy, because injectable regimen, of course, it's a lot of discomfort to the patient. Adherence rate is low, plus side effects are quite high. So we have gone into an all oral regimen since April 2022. Let's see the milestones of DRTB management in India. These are the milestones. And introduction of the newer drugs, bedaquiline and delamanid, was of course game-changing for the national TB program. And as I said, the UDST policy. Now, where does India stand in the global TB picture? So as you can see, India is the top contributor to global TB burden. 28% of the TB cases in the world they are from India. So 28% of the global TB burden. That is what India's contribution is to global TB burden. And let's see the annual incidence rate. It is 210 per lakh population. So it might seem as a low rate when you just look at the rate, but consider the huge population of India, 140 crore population of India. See how much it translates into numbers. It is coming into the absolute numbers of some 29 lakhs. So that much high is the burden of TB in our country. And the mortality due to TB among the HIV negative people is 35 per lakh, the mortality rate. And you see the burden of MDR TB, about 2.5% of the new cases of TB diagnosed is MDR or rifampicin resistant TB, and 13% of the previously treated cases, they are MDR or RR-TB. So the rates of MDR, RR-TB are also quite high in our country. So when I'm talking about these figures, please note that these are the latest available full data. That is for the year 2021. So the reports which were published in 2022, whether it is India's or WHO's, whichever it is, that contains data for the year 2021. Now 2022's data will get published this year, World TB Day, on March 24. So in the 2023 report, you will have the statistics for the current year. Now this is just a summary slide to see what are the NTB strategy milestones for 2025. We are supposed to reach a 50% reduction in TB incidence rate of which we have, this is global in terms of global statistics, not India's alone. 50% reduction in TB incidence rate, we have achieved only 10%. TB mortality, we are supposed to reach 75%, but again, it is 5.9% only what we have reached. Catastrophic costs are supposed to be 0, but 48% of people with TB face catastrophic costs. Now let's see what the burden of TB globally is in terms of incidence and prevalence, and what is India's status on it. So you can see this is the global map depicting TB incidence for the year 2021. As you can see, India is in the highest band when you see the rest of the world. And estimated TB incidence rates. So the global TB incidence rate increased by 3.6% during the 2020-2021 period. And India, as I told you in the previous slide, has a rate of 210 per lakh population. And as compared to the previous year, this is 19% higher. So India, the estimated incidence rate of India is higher than the previous year. Now, you can see from the map that India is belonging to this particular slab. Now, there was this National TB Prevalence Survey, which was carried out in India. It started in 2019. And due to COVID, it was stalled for a few months, and then it was restarted, and finally it was completed in 2021. And the report was published on World TB Day last year in March 2022. So till now, we talked about the incidence rates. So this is prevalence of TB in India. So this survey gives you a snapshot of all the old and new cases right now present within the country. So you can see the prevalence of microbiologically confirmed pulmonary TB in adults more than 15 years age group is 316 per lakh population. And you adjust for the age and other forms of TB, it comes to 312 per lakh population. And the highest is in Delhi and lowest is in Gujarat. And there is something called as TB infection. And I suppose everybody is aware of that. The TB disease is different and TB infection is different. TB infected people, they have a 10 to 15% lifetime chance of progressing into the disease, TB disease. And we assume that almost 1/3 of the population in the world is infected by TB. And in India, our estimate is that nearly 30 crore people are infected by TB. So the prevalence of TB infection among population above 15 years of age is 21.7%. So these are the very high rates or a high proportion of burden of TB in India. The report also had a very significant finding that for every case notified, 1 to 2 cases of TB are missed, which is of course contributing to the missing millions in case of global TB. So for every case that is notified to the public health system or to the health system in general, so unless they're notified, they're not put under treatment. So for every case notified, 1 to 2 cases are being missed. And if you look into the reasons for why they are being missed, the seeking care or healthcare seeking was not present for 64% of the population. And why is it happening? Most of them ignore the symptoms. So being respiratory symptoms, a lot of trying self-treatment, home remedy, ignoring the symptoms, all these happen for symptomatic patients, and that results in them not seeking care. So these were also the findings in the TB prevalence survey report. So how can we help the missed TB cases? It's of course by improving access to TB diagnosis and care services. And we really need to build collaboration with various private providers as well, which is very important in terms of correct treatment, completeness of treatment, and proper follow-up. By law, as you all know, in 2017 itself, the notification of a diagnosed TB case into NICSHE is mandatory by private providers. It is mandatory by law since 2017. But still we have a lot of gaps in it. Private sector is still not notifying. Again, that is a multi-dimensional problem. There are problems from the private sector. There are problems from the government system as well. That is, again, a whole new range of things to discuss. Now, let's see the global estimates of number of incident TB cases and the attributable selected risk factors. As we all know, undernourishment leads to be the major cause of cases, TB incidents in the world as well as in India. So the large number of TB cases, the incidents, it is highly influenced by undernourishment. So with such large number of undernourished children and undernourished people in the country, that is again contributing to the burden, or like to the burden of TB in India. And undernourishment, and another poorly recognized causative factor, attributable factor, is housing condition, which is still not that widely recognized as a contributory factor. Like undernourishment, housing in terms of ventilation, that is very contributory factor for causation of TB. So based on this, there is a separate school of thought who proposes food as a social vaccine for preventing TB. So food as a social vaccine for preventing TB is something the research world is exploring as trials. A large trial is happening in the state of Jharkhand. It is again funded by the ministry. It's called the Rations Study. And it is, the reduction of, a reduction in incidence of reactivation of TB among household contacts of TB patients. So that is the Russian study that is ongoing in the state of Jharkhand, where they're doing a clinical trial where for selected clusters, they are providing clusters of TB patients, they're providing nutritional supplementation in the form of dry rations, and seeing the rates of TB incidents in their household contacts and various other things. The protocol paper is published. You can look it up. I think I've shared it in the drive also. So it's an ongoing study. The results are not yet available. So that is one thing to look forward to. But the role of nutrition and housing needs to be considered very seriously, especially in a country like India. And as I told you, poverty and hunger. With the COVID pandemic, the world as a whole has gone back in terms of the achievements made in eliminating poverty and hunger. You can see more than 4 years of progress. This is according to the SDG report. More than 4 years of progress against poverty has been erased due to the pandemic. And about 1 in 10 people worldwide are suffering from hunger. So there is lack of regular access to adequate food. So with these conditions prevailing, unless these conditions are addressed properly, we cannot completely achieve TB elimination goals. So that is something which is to be kept in mind when we talk about TB elimination. let's look into TB case notification. How is it going in the country? So country and in the world. So as you know, India has a very robust digital information ecosystem called Nikshay. Nikshay is a revolutionary change which happened in the program as well. So this helps us to get a real-time data on what is the status of TB cases in the country. So if you see the global picture, during this is a graph showing the trend over the years. So you can see during the high level meetings and SDG target setting and NTB strategy adoption time, during that renewed global attention to TB and a renewed commitment by global nations towards TB. So that is why you can see a sharp increase in the notifications compared to the previous years during that period. And there was substantial progress that was made during that time in terms of TB case notification. However, when we were in the peak of those progresses being made, we were hit by the pandemic and the world dropped down to these levels. So there was about 18% decline in global TB case notification. You can see from the graph. And there has been partial recovery only in 2021. So if you see the reason, the contributors for this 18% decline in TB, you can see that Southeast Asia region is contributing the most to the decline. And 67% cases of this case decline happened from Southeast Asia region, and India, Indonesia, Philippines. These are the top 3 countries who contributed to that decline. So there was remarkable decline in TB case notification from the country also during the pandemic. This is again another slide which is depicting the position of countries, which showed a reduction in TB notification in 2020 as compared with 2019 and 2021 as compared with 2019. India is topping both the statistics. Now, these are called the missing millions. So this you can see is this green line here, what you can see is the estimated number of incident TB cases, which should be reported as per our estimates. So as per our global estimates, these many cases should have been reported each year. And this black line shows how many were actually reported. So you can see there was a wide gap again over the years during the renewed commitment time. That gap kind of reduced. In fact, in 2017 or 18, the World TB Day's theme was to reach the missing millions. So there was substantial progress we were making in that particular area. But again, the pandemic kind of pushed it back, and we can again see a drop during this period. And as in case of notification, like as we told in case of notification, India and Indonesia are contributing maximum to the missing millions. Now, what is the implication of this declining TB notification? What is the impact of that? Or what do you mean? Okay, the TB case notification is declining. So what does that mean? So we understand that there is reduction in reported number of people newly diagnosed with TB during 2020 and 2021, thanks to the pandemic. So what does that lead to? It means that number of people with undiagnosed and untreated TB has increased, right? Due to the pandemic, there were several restrictions in terms of health system, as in health systems were diverted to COVID related activities. There was reduced funding. Everything was diverted to COVID control. People also had lack of access to TB essentials, essential TB care services owing to the lockdowns and stigma and fear of contracting COVID if they go into a hospital. So those accounting for all those factors, there were large number of undiagnosed and untreated. What would this lead? So these people who are going undiagnosed and untreated will have a higher chance of succumbing to TB. That is, they have a higher chance of dying due to TB. Also, within that time, since they are untreated, they also transmit TB to their contacts. So the community transmission of infection also happens in a large scale due to these untreated cases. So later, this will lead to increased number of people developing TB. So that is the implication of the declining TB notification in terms of incidence of TB. Now let's look into TB deaths. So TB deaths have risen for the first time since 2005. So in 2019, it was 1.2 million. In 2020, it's 1.3 million. Now see, in global TB deaths, we are back to the 2017 levels. So you can see among the HIV negative people in absolute numbers, if you see, the world had 1.4 million deaths. And among HIV positive people, 1.8 lakh people, and a total of 1.6 million people across the world died due to TB. And this increase in deaths is contributed mostly by these countries, India, Indonesia, Myanmar, and Philippines. So here again, there also India is topping in terms of TB deaths as well. Now, how did disruption of services during COVID pandemic contribute to the TB deaths? So disruptions in TB detection and treatment affect those who already have TB first. So as I told earlier, the undiagnosed and untreated individuals have higher risk of death than those started on treatment, and also they contribute to increased community transmission. So there is more immediate impact on TB deaths. That is, TB deaths will increase, and in coming years, we can see an increase in TB incidence as well. That is a delayed impact on TB incidence. So this is how it operates. Now let's see what is India's share in global TB mortality. It is 36% of TB deaths in HIV negative people, and 32% of the that is happening in India. Now you can see the HIV negative TB mortality in India. It is 35 per lakh population, and there has been 11% increase between 2019 and 2020. Now, these are the mortality rates of DRTB in India. You can see among the XDR and MDR TB population, the mortality rates are quite high. Let's talk about drug-resistant TB. So the global trend in estimated number of incident cases of TB, you can see it had dropped, and 26% of the drug-resistant TB cases in the world are from India. So you can see that 3.6% of the new cases diagnosed in the world and 18% of the previously treated cases are either MDR or RR-TB. And in terms of drug susceptibility testing, only 71% of pulmonary TB cases would get a rifampicin sensitivity testing. So this is again the global map showing MDR, RR, TB. India is again the hotspot. Globally, there has been 6.4% increase in XDR and pre-XDR cases during last year. And missing cases in DRTB, you can see this is the estimated, the green line shows the estimated number of DRTB cases which have to be notified actually. And the blue line shows, and so this will show, so this, as you can see, is showing a steep gap, the estimated number and the actual report. So India is one among the 10 countries contributing to 70% of these missing cases. And there has been a 9% reduction in MDR TB cases on treatment in India. Again, this is the proportion of people who were, or global number of people reported to be enrolled on MDR TB treatment. And a worrying fact is that pediatric DR TB is also rising. Looking into TB preventive treatment. So the TB preventive treatment this is the graph showing how much of TB preventive treatment people have been covered by TB preventive treatment. So the UNHLM had laid down certain targets for TB preventive treatment. We were supposed to reach. So the UNHLM has set their target year as 2022, and there is a high-level meeting of UNHLM happening in 2023 September, where they will evaluate the progress made from 2018 to 2022. So the target was to give TPT to around 30 million people, all ages. But how far have we reached? 12.5 million, the global statistic. And people living with HIV, we were supposed to reach 6 million people, but we have reached 10.3 million people. So this is one target which consistently all the countries have been doing well, people living with HIV. And especially in India also, we have been doing very good with TPT coverage in people living with HIV. So that is the sole indicator which we are in a good shape. So household contacts aged less than 5 years, that is conventionally TPT is given to household contacts less than 5 years age only from olden times. So that the target to reach for 2022 was 4 million. We have reached only 1.6 million. And recently, many countries have introduced household contacts above the age of 5 years also to receive TPT. So that the target is 20 million, but we have reached a mere 0.6 million globally. Now let's see what India's TPT targets are. India had this ambitious goal of attaining 60% coverage of TPT by 2020 and 90% by 2023. That is our 6 million people to be covered. And what is the evolution of TPT strategies in India? TPT, or it was called isoniazid preventive treatment. Or isoniazid preventive therapy, IPT. And it was given only for children less than 6 years of age who were contacts of the pulmonary TB patients. So it was programmatically introduced in RNTCP in 2005. So IPT was given only for children who were household contacts of TB patients. And in 2017, government programmatically introduced IPT to all people living with HIV. And we have been doing very well in that PLHIV targets because, of course, it is years of advocacy that has taken place and a concerted effort of both national programs. So we are good in terms of PLHIV coverage for TPT. In 2021, the NTP introduced TPT for all household contacts of index TB patients, irrespective of their age or HIV status. So that is the major change which happened in 2021. And right now, TPT is offered to all the household contacts of diagnosed pulmonary TB patients who are bacteriologically confirmed. And also a novel regimen, shorter regimen, 3HP, which is isoniazid and rifampicin in once weekly dose for 12 weeks. That is 3 months. So that is 3HP. This was introduced in TB preventive therapy guidelines of India. So that again, how much we have achieved. So even now, our under 5 uptake of TPT is 48% only. And this adult TPT uptake is in a very nascent stage. We have achieved only 6%. And so this itself, so this requires a lot of awareness activities, because for somebody to take TPT, it's not easy to make the contacts of TB patients take TPT because they are symptomless, and asking them to take 6 months medication when they don't have symptoms, when they are not the patients, that is difficult when you see at the program level, but we have to do it given the fact that majority of our population is TB infected. And it has already been shown that TPT alone can cause an annual decline in TB incidence by 8.3%. So our required decline is at least 18% per year in the annual incidence of TB. So 8.3% of it will be taken care by TPT alone as per modeling studies. So that is why we are pushing for TPT as well. And BCG vaccination, this is the other preventive measure which we have, and we have been standing good in BCG vaccination with 95.2% coverage in India. Now, the financing on TB, UN high-level meeting required countries to devote this much money for TB-related activities. And but the spending on TB prevention, diagnostics, and treatment services in low and middle income countries, it is far, far away from the targets set by the UN high-level meeting. And talking about TB research funding, again, it is very, very much behind what is set as a target. Now, what is the funding for NTP within this is a country's program funding, and total program cost is this much in millions of US dollars, and the government of India is contributing, or the domestic funding is 934 million US dollars, and rest of it is coming from the international donors. Now, let's move into the catastrophic cost due to TB. So when you are reading about the burden of or like the catastrophic costs of TB, never directly compare these two, the SDG indicator of catastrophic health expenditure and the NTB indicator of catastrophic costs due to TB. So SDG indicator is a proportion of population with large household expenditure on health as a share of total household expenditure or income. And it is for the general population, and it includes only direct medical expenditure. So the cutoff defined for it is different. Whereas the NTB indicator is particularly for the patients in the national TB control programs. Okay, it is the percentage of TB patients and the households facing catastrophic costs due to TB. It includes both direct and indirect expenditures, like it includes direct medical expenditures as well as indirect expenditures like travel expenses, wage loss. So take care never to compare these two. It should never be compared together. So if you see the catastrophic cost due to TB in India, there is no nationally representative study for that in India. And a recent systematic review estimates the direct and indirect patient costs for drug-sensitive and drug-resistant TB care in India. And it is 7% to 32% catastrophic cost for drug-sensitive TB patients and 68% for DRTB patients. Now, the Sustainable Development Goals and the Universal Health Coverage. So the countries as per SDG the countries are supposed to achieve universal health coverage by 2030. So what do you mean by UHC? UHC is nothing but everyone can obtain the services they need without suffering financial hardship. So this is the SDG target for achieving UHC. And one of the components of the Service Coverage Index, UHC Service Coverage Index, is coverage of TB treatment. So UHC for achieving TB targets is quite important. It is imperative to achieve the TB targets defined, and the reversals in progress in the number of people enrolled on treatment makes us infer that the global targets set by UNHLM is now appearing to be out of reach. So it's important in achieving TB targets. So, for example, we have NTB strategy milestone of 75% reduction in TB deaths, which requires that only 6.5% TB patients die from it. This is feasible only if everybody with TB can promptly access the diagnostic and treatment services. So now let's see the progress made or not. Coming back to these figures, we have to achieve a TB death decline of 75%, or let's go to the 2020 targets. We are supposed to achieve 35% decline. It has declined only by 5.9%, and also there is a major climb up in the 2021 statistics, as we discussed before. And look into the incidence rates. We are supposed to decline the incidence by 20%, but we have reached only a 10% reduction. And in India, to achieve the milestones by 2025, we need 18% decline in annual incidence rate. But currently, we are at a mere 2.5%. Now, globally, the cumulative reduction of TB incidence rate is 10%, as I told in the previous slide, which is exactly halfway to the 2020 milestone of 20%. And by WHO regions, if you see, African region is the front runner in that. African region is the one which has achieved the first milestone with a 26% reduction. So that is regarding the achievement made in incidence rate. Now look into the TB treatment success rate. What is success rate? It is the regimen completion or the successfully completed treatment patients. That is what you mean by success rate. So if you can see, so this is the number of people newly diagnosed with TB and enrolled on first line treatment. And this is the MDR TB treatment success rate. So globally for drug-sensitive TB, it is 86%, and for drug-resistant TB, it is 60%. And in terms of India's success rates, we have 83% of drug-sensitive TB cases having a successful treatment completion, and 57% of people with DRTB having good success rate, treatment success rate. So, which means that once they are brought into the program or brought into the treatment pathway, they are kind of taken they go into completion. The probability of going into completion is quite high, if you see. Now, let's see the TB treatment status of various groups. So if you see TB new and relapse cases, the percentage of people receiving TB treatment declined by 18% in the year 2020 as compared to 2019. Drug-resistant TB, there was a decline of 15%. Children, that is pediatric TB, 24% decline. Pediatric DRTB, 42% decline. And individuals receiving TB preventive treatment, there was a 22% decline. And the childhood contacts, under 5 contacts receiving TPT, again, 11% decline. So these are all the decline figures in 2020 as compared to 2019, which is, of course, worrying for the program. So now what can you conclude from this? The impact of COVID-19 pandemic has been immense to the world as well as to India. It disrupted essential TB care services. Diagnosis and treatment was affected. The years of progress which we made was reversed or stalled globally and in India. And the top priority now is to restore access and services related to essential TB care, which is happening, but we need more attention into it. Otherwise, TB will replace COVID-19 very soon as the single infectious agent causing maximum number of deaths globally. And poverty and undernutrition is on the rise. As you know, war in Ukraine and conflicts in different parts of the world, that is pushing more and more people into poverty and undernutrition. So unless and until these important contributory factors are addressed, we cannot achieve reduction in TB incidence and mortality. So how to progress? The way forward, advocacy to spread the message of importance of TB as a public health problem and need for TB elimination. Unless more people know about TB and the fact that it is curable and the fact that TB preventive therapy is available, there will be stigma associated. And as you say that it is you have to be sensitive while addressing stigma issues. Like, you should not talk openly, you should be careful about it. But when the time is ripe, you have to openly challenge the stigma. And it is high time that we challenge the stigma of TB and we address that stigma, bring in more awareness, because a huge proportion of people, the cause for stigma is due to lack of awareness. So as a public health professional, as a practitioner, spread the word of importance of TB control in your daily practice and encourage more people to utilize the healthcare services which is provided free of cost by the government, and increase the universal health coverage. That is, of course, very, very important, as we discussed. Strengthening patient support systems, supporting them in terms of social security, nutritional support, everything is important. So as you know, Pradhan Mantri TB Mukt Bharat Abhiyan, which was started recently, it focuses on identifying Nikshay Mitras, which is essentially identifying individuals, corporate houses, NGOs, who can provide nutritional support in the form of dry rations to TB patients. So that is a scheme which has started recently, and that again identifies nutrition as the important factor to control TB or eliminate TB. Addressing determinants of TB like undernutrition and poor housing. Again, poor housing is something which is still not looked into properly. Undernutrition at starting, I would say. And we need robust and transparent data system, which is very, very important. We have to first acknowledge the fact that there is a problem. Then only we can address it, we can work towards it. So acknowledging the problem is very important. When you acknowledge a problem, it's not tarnishing your country's image. It's not a PR crisis. Health risks in particular are not PR crisis. It is the life of humans that we are dealing with. So we need transparent data systems, improved health financing, including research, and more attention into research and development of diagnostics, therapeutics, vaccines, and implementation strategies as well. So that concludes the presentation.
Thanks a lot, Swathi. It was a very comprehensive, and you have covered a very big, huge topic, and you have covered it really well. So thanks a lot for that. So just sort of summarize what you just told in few sentences. Are we close? I don't think so. And are we going to end TB by 2025? I think it's impossible.
Yeah, the chances are very dim.
Yeah, I mean, calling it dim is also being very hopeful. I think there are no chances. And, personally, I've always felt TB to be more intimidating when compared with cancer. I feel we can still defeat cancer, but I don't think we can defeat TB. And current issues, like you mentioned, poverty and hunger being one of them. And recently one report came out where the government was very proud in, saying that 800 or around 80 crore people have received free ration, which, actually highlights the amount of malnutrition in the country and the amount of poverty. And with the global hunger index also, which came out recently, and it's all very alarming. And the government was not agreeing to that index, but we can sort of correlate with TB levels going up, TB cases going up, anemia going up. It's all sort of collectively makes a lot of sense. And again, the private versus public health system issue where notification becomes a huge problem. Like you said, the national the strategy is very, very well written. I wasn't aware there was a new one in 2020. I was reading the 2017 one, but it sort of, it mentions the active case finding and it mentions vulnerable populations like in depth. But again, I feel I don't think we are making health accessible for that vulnerable population, especially people in slums and the prison health. That's another issue. There were a few questions in the chat box. Mohana Priya wanted to ask, where are the lacunae in the NTP program and how we can address it? So the perspective, I think what she's trying to ask is, we have our stakeholders, and most of the program directors, secretaries would be civil officers. So if I were to approach, say an IAS and ask them, you should do this to make this program better, in your perspective, what would that be?
So in terms of NTP program, it is one of the well-running programs in the country. If you compare any other health program, it is very well written. So if you see the NSP also, or anything, any guideline related to NTP, it is very well written. It is touching upon every aspect of almost every aspect of TB. But what happens is, when it comes to the implementation level, to the grassroots level, the implementation level varies hugely. Different regions or different states take it up differently. State health is a state subject, so the states have an upper hand in implementing. Some states implement everything written in the program, every single thing they try to implement, but some states do not. And so that kind of variation is very much there in our country. And India, as much as it is a huge huge plus point, which we say we have a diverse country, it is also making such solutions complex, because the epidemiology of TB itself is quite different in each place. As you said, the urban slums, which is one of the focus areas, the conditions there are, oh my God, like if any of you have worked in urban slums, I have worked in urban slums, so across the country. So I have realized that in terms of living conditions, the rural poor are much better when compared to the urban poor. The condition of urban slums in India are alarming. So in such a place, I don't even find it fine. I mean, I don't know how to talk about TB to them. They have such poor ventilation. The nutrition is again compromised. Contacts, household contacts, like whole range of problems. So we have a program which is well written, but it is always at the mercy of enforcing officers, who if a certain area is having well motivated, well read officers or staff present there, that area gets the advantage of the program. But I really don't know, maybe a lot of motivation from the part of government, a lot of need-based, as in the demand should come from the people. That is another thing which can. So which is why I always stress on advocacy, spread the word, spread the word, spread the word. Because still people don't know how much big a problem this is. Sadly, doctors don't know how much big a problem this is. Many doctors don't know how much big a problem this is. So tirelessly advocate in your everyday life to make people aware that this is a problem. And I think we need an awareness, which we have in case of HIV. HIV we all have, like I think even kids know about that. Okay, HIV is something serious. They know about that. So that kind of awareness we need among the population as well. So I don't have a straight answer to it. This is what I think about.
No, I totally agree with you. There's another very important point, which actually Dr. Sonali brought it up. So pre-COVID era, if you see, masks were a huge stigma. Anybody wearing a mask would be treated differently, and especially TB patients. And thanks to COVID, masks have become very normal. It's a part of our daily life now. And so that's what she mentioned, actually. Under prevent, we need to emphasize airborne spread, which was, not previously emphasized. And we have also one question. Can we have the state-wise data for India? Is there any data source which is available?
Yes. State-wise data for most of the indicators, it's available in India TB report. So every year, March 24, which is World TB Day, Central TB Division releases India TB report. So the latest India TB report I have already put in the drive, which you have shared. It is available in the public domain. So another point which I have to stress to all the public health professionals over here, getting data from public domain is an art. You have to play around with words. Like India TB report is quite a straightforward one, but you have almost every data in public domain. Most of it, I would say, not 100%, but most of it. So just play around with keywords. Try Googling a lot of times. You will get, like, there are n number of data sets available.
There's another question where, do we have enough pharmaceutical support to address such large number of cases?
Pharmaceutical support in the sense, like NTP has its own supply chain management system. There is separate set of people working on it, and it is centrally procured. All drugs, whether it is drug sensitive or drug resistant TB, it is centrally procured by the Central TB Division through the government medical store, GMSDs, and CMMS store. Through those centrally procured, and then they are distributed to the state drugstores. So each state NTP has its own drugstore within the STO's office attached to the state TB office. There will be state drugstore also. From the state drugstores, based on the drug request through Nikshay Aushadhi, there is a portal called Nikshay Aushadhi, which NTP staff use to send drug requests and procure the drugs and consumables. So from the state drugstores, it is supplied to the district drugstores, and from the district drugstores, it is supplied to the TUs, tuberculosis units, and the peripheral health institutions. So that is the supply chain system in NTP. It is a very reasonably good supply chain system which you have under NTP. And drug-resistant TB drugs, again, Delamanid and bedaquiline are directly procured by CTD, like all the other drugs. It is government is paying for, every drug is free of cost, and Delamanid and bedaquiline, if you want to know, like an interesting fact, for those of you who are not aware of it, it is patented. They are patented drugs, Delamanid and bedaquiline. So these are supplied by, bedaquiline is by Johnson & Johnson, and Delamanid by Otsura, I think.
Yeah.
So these two drugs are patented till 2023. July 2023. These are patented drugs, which means no other companies can produce these drugs. So the cost of these drugs are quite high, which the government is paying now, and around 36,000 for bedaquiline for a 6 months course. So the TB survivors, and what happened is the companies filed for an extension of this patent. They were telling that companies can produce drugs once the patent is over, but now they have filed for an extension of patent, which has led to TB survivors filing a case in Mumbai High Court, and it is ongoing, and they have asked government to prevent the extension of patent. So if the patent is extended, again, the government has to pay huge amounts, and there will be shortages and all that. If generic companies can produce it as a generic drug, then it will be widely available.
Yeah,
right now it's restricted.
For those who are interested, I think this point is covered really well in this book. This book is called Phantom Plague. It's by Dr Krishna N. So those who are interested in understanding the politics behind tuberculosis evolution, I think this is a great book to read. There's another question. Could you tell us more on the no injectable policy? Has this been rolled out, and are places now following this?
Yeah, so from 2022 onwards, whichever new patients are started on DRTB regimens, they are supposed to be on a no injectable regimen. And also, we have BPAL regimen, which is all oral regimen again, bedaquiline, protoman, linezolid. That is given on a trial basis to people in DRTB patients in the program. So if you ask me if 100% no injectable policy has been implemented, I do not have any specific data, but by policy, but after 2022, whoever has been started on a DRTB regimen are not having injectable, but all the earlier continuing people might be having injectables.
And Deepak sir has a comment. Deepak sir, please, can you go ahead and share your experience?
Hi.
Hi, Deepak.
Hi. Yeah. So no, I think we've discussed this a number of times, Swathi and me, but I think steps. I don't know if it's there across the country because I'm not sure. But Kerala has this model called steps, which means that we have at least in our college we have NTP drugs provided even in private medical colleges, which means that if a patient with TB, at least in our college, what happens, this does not happen in every college, but what happens in our place is that regardless of whichever department diagnoses TB, we have what is called a single window system. So whichever department diagnoses TB, we get called. Like community medicine gets called. So what that means is that whoever gets diagnosed with TB, we can send notification. Like notification will go via us, and they can be started on the NTP regimen itself. So we have a policy where we do not dispense ATT drugs from our pharmacy. So everything comes via, but I don't know, this is the norm. This may be, an ad, it may be an off case or something. I don't know I don't know if we can generalize it. That's, I think, a good model to follow, because if everything can be routed through a single department, but very often what happens is that the center is usually pulmonology. Like the nodal officer of the private sector will always be pulmonology, but we see a lot of extrapulmonary TB in the private sector, because invariably all this cough, cold and all will somehow go via the PHC and end up in the public sector. But in the private sector, there's a lot of people who come with pain abdomen and all of those things, which invariably becomes abdominal TB or spine TB or something of that sort. So I think at our center, we see more. I mean, I think it's not a proper number, but I would think that we see almost as much extrapulmonary as much as we see pulmonary. So the problem is, if the nodal officer is pulmonary medicine, nobody's going to call pulmonary medicine and tell them that we have a case of abdominal TB, right? Because it's not his headache. So this is a model that we follow at our place, but it's, I think, something that's worth emulating, because what we do is we start them on the NTP program and either refer them back to their local PHC or continue from our own PHC, but the government supplies this. Of course, I must say that is only because we have the most amazing DTO, district TB officer, and he's a very cooperative guy, and we are all on the same page. I mean, there are other districts even in Kerala where DTO and college people don't get along and all of that, but I think we are fortunate to have a very young DTO who's around our same this thing. So I think that's probably helps. The other thing, one more thing that they do is, I don't know if it's his innovation or whose innovation, the NTP actually has calendars on which the entire protocol is written. So I think when we go to these DTO meetings, he will make sure that the STLS goes to the private hospitals and keep those calendars. So he's like, even if they don't know it, it's there on the table. And I don't know if it's his innovation or whose innovation, or the program's innovation. But what that does is it's like a constant reminder that the NTP is there. So please, please send them to us. So I think that's something that's quite
well, that's a great point. But things, the way things Kerala does is usually something which reaches the rest of the country. Maybe
there are problems, but
a lot of things, when that should be appreciated, I feel we should openly appreciate things. But that's actually a great model which rest of the country could sort of emulate. Somebody has asked, Dr. Tenderland has asked, where can we get the ongoing updates from the Jharkhand trial that you were talking about, the Russian trial?
Yeah, so just Google Rations trial. You can find the paper. It's only the protocol paper which is published. The results have not yet come.
Okay.
So you can just go through the protocol. Just Google Rations study, RATIONS. I think I've put it in the drive also.
Yeah,
I'm not sure.
the links I will share in the description of this video when I upload it on YouTube as well. I think we can take one last question. If anybody has any comment or any question, please, you can go ahead, raise your hand and I can unmute you. If anybody wants to give any feedback or share your own experience when it comes to dealing with TB patients. I think, Dr. Sonali, if you can just unmute yourself and...
Hello.
Hi, yeah.
Yeah, thank you so much, Dr. Swathi. I feel more comfortable about my ignorance after hearing you, because you made us realize about the complexity and how vast this is. You know, I keep saying things from a quality perspective. I also think TB is a great example of, you know, the cascade of care, which is there in many conditions. But TB sort of manifests it very clearly. So people fall through the cracks, and even if they've been screened or detected, they don't continue on to treatment, or they have side effects. Nandita Venkateshan, you know, the patient advocate, is unfortunate, but, you know, very good, strong advocate for TB. So I'm curious whether the latest strategy makes mention of these quality gaps and suggests ways to address them. And I think in your presentation also, you mentioned, I'm forgetting the figure, something around 58 to 80% or some gap like that. Yeah.
Yeah, ma'am. Yeah, thank you so much for the kind words and for being attending the presentation. So basically, as you said, everything is patient-centered. The NTP as a whole now is so much centered on patients, and as you said, most of the times this adherence problems occur due to lack of awareness. Again, they don't know what to expect, and nobody's telling them like, you are taking treatment, expect these things to happen. We are giving counter medications for that, or ask us for that when you have these problems. That particular message is not going into patients properly, which again is a deficiency in training. I would say a uniform training, standardized training, which should happen. So when we talk about that given in terms of care, a lot of it depends upon how they are trained as well. And NTP right now, what they are lacking is a uniform training system or a standardized training system for all cadres, not only the medical officers, but to all cadres. So which is what the background work is going on. I am still part of a project which is looking into that, the IDFIC TB project. So which is essential to improve the quality part in TB care, I think. So I feel training is a very important part, though the policies are written as patient-centered.
Thank you.
So I think we can wrap up the call for the day. Thanks a lot once again, Swathi, for your presentation. If you could just share your Twitter handle as well on the chat box, people can follow you on Twitter and get in touch. I think you're on LinkedIn as well.
Yeah. I am.
Any further questions I think can be taken up personally. I'll share her email ID as well in the YouTube video once I upload this.
Okay, sure. So thank you so much, Parth, for this opportunity to converse with young health professionals, public health professionals, and It was really nice speaking to you, though the presentation went a bit long. I think at least something to read up, some interest into the area of TB for all the young people. So thank you so much.
Thanks a lot. And we'll be having our next forum on global surgery, and that'll be next month. So I'll get back with more details for that. Thank you all for joining on a Saturday evening, and I hope you all have a great weekend. Take care. Bye.
Thank you. Bye.